for our friends joining us.
Thank you so much for joining. Today we're going to do it a little differently. We're going to start with the Q&A at the beginning, and then we might have a small one at the end as well. So we're going to start with the Q&A and then go into the presentation. We have Trish here today. She's an OBGYN PA, and whenever you're ready, Trish, feel free to take over.
Okay, so hi guys. Thank you for joining us. Some of you may have joined a couple of my other talks slash lectures. So I welcome you back for those that are coming back on another platform. And for those who are joining us for the first time, joining me really, I'm sure you guys are all experienced with PPA Pals and everything that they're doing, which is absolutely amazing. So my name is Katricia Durrett. Everybody calls me Trish, and I am an OBGYN practicing physician assistant, and I do per diem work in surgery where I essentially manage the floor. And I'm kind of just going to talk a little bit about myself and what I do on the day to day, more or less, as an OBGYN PA in Brooklyn. Okay, so I originally started in the medical field as a respiratory therapist. Life kind of took me in a different direction. I was always deciding between MD or PA, I think, like most of us, right? And so life took me in the course where I became a physician assistant at Stony Brook. I got my bachelor's there. I worked for a few years, gave myself a 5-year timeline to go back and make the decision between MD or PA. I then met my now husband, and I really wanted to be able to have a good work-life balance, have a good salary, have some sort of autonomy, and practice medicine-based care. And the best way to encompass all of that was to be a physician assistant. Based on my research, I found that it's optimal in terms of having good work-life balance and practice in medicine, and being able to do all the personal things you may want to do that you may not necessarily have time to do as an MD. So I went back to school, retook expired classes, applied, waitlisted the first time, reapplied to only one school, SUNY Downstate in Brooklyn. I was waitlisted again and ended up getting in. It was a first master's program, and I was class president. I finished with my master's, and I'm now working in a hospital in Brooklyn, officially working for a little over a year. So fast forward. So first, I just want to go over a quick disclaimer that obviously everything that I discussed tonight is of my personal will and volition and my opinion only. Nothing regarding the opinion of my employer or anybody else of that nature. So as an OBGYN PA, I work essentially 3 days a week. I work predominantly in OB, also known as obstetrics, where we deal with pregnant patients. GYN is more is gynecology, so we're dealing with women's health, abnormal uterine bleeding, menopausal bleeding, postmenopausal bleeding, gynecology, oncology related cases, fibroids, sarcomas, abortions, and things of that nature. We see more on the gynecological scale. So a day in the life in OB, my day essentially starts in triage, which is considered the pregnancy emergency room. And those patients essentially are coming off from, the street outside. They're coming in with complaints or their provider's office. So those patients come in with complaints of anything ranging from vaginal bleeding to not feeling their baby move, to I was sent over because my cervix is short. I was sent over from my doctor's office because I don't have enough amniotic fluid. I need to be induced. To I was recording my blood pressures at home and they were a little high. To this patient's blood pressure is 220 over 140. We need to get her started and induced and possibly sectioned before being eclamptic, and etc. So those patients come in, we assess them as needed and make the decision to say, we're going to work up this patient for whatever their chief complaint is. And then we're going to decide if we're going to admit the patient to our service, continue to treat them and monitor them, or be able to monitor them for whatever acute issue, and then send them home to follow up outpatient care with their primary provider or with us, whomever their provider may be. I also first assist in the OR where I go into C-sections and I go ahead and take the scalpel, do the sections essentially beginning to end with the assistance of the attending. And I have delivered as well. I haven't been doing that as much, to be honest, with COVID affecting things and me predominantly spending time in the OR. It's a lot easier to learn to deliver a baby than it is to be in the operating room. So that's right now my primary goal is just to completely master that And then I'll just jump back in to delivering. And in GYN, those days are usually dedicated to a lot of consults. So usually we have patients either coming in from their provider or from home, or even from inside the hospital, admitted to a different service with a lot of complaints of abnormal uterine bleeding, which is the bread and butter essentially of gynecology. So whether it's menorrhagia and excessive bleeding, intermittent bleeding in between your cycles, or postmenopausal bleeding, all those things we see, or a patient that may be aborting, unfortunately, in the ED, we see all of those patients. Also pre and post-op patients for any GYN oncology related cases, fibroids and myomectomies, and anything of that nature as well. Does anybody have any questions? There was a lot of information I gave just now. So does anybody have any questions regarding anything that I kind of went over?
Yeah, we've got a few questions here. So let's see, I'll start with this one. So somebody asked, when did you know you wanted to do OB/GYN?
Okay, I caught half of that. There was the lag. So I presume it's when did I know I wanted to be an OB/GYN PA or a PA?
OB/GYN.
Okay, so I tell everybody this, and the truth is I hated OB/GYN. I was like very anti-OB/GYN. I even tried to do like 2 surgical rotations in place of my OB/GYN rotation. That's how bad it was. And obviously that negotiation tactic did not work in my favor. And I actually did my rotation at the hospital that I'm currently working at now. And that rotation changed my entire perspective on OB/GYN and made me absolutely fall in love with OB/GYN. So it's during your clinical rotations as students a lot of the time that you figure out what you really are interested in, because you can read as much as you'd like, but until you're actually in the field and seeing things and being part of procedures, and being a part of the day-to-day and specialties and subspecialties, you won't really know what you're really passionate about unless you actually, get in there and you actually try and make an effort and have the exposure. So the rotation actually is what made me fall in love.
Wow, that's crazy. You started off hating it and it's what you
love. I'm just like, oh my God, a vaginal exam? Holy cow.
Yeah, and good thing that didn't really work out in your favor for your rotations, kind of helped you find what you love. That's awesome.
Totally fell in love.
And the next question is, so how much autonomy do you have?
I have a pretty decent amount of autonomy. I think that for me, like the way it works for us is when patients come in, the patients see the nurses at the front desk first. They come in with whatever complaint, whether it's from the doctor's office or off the street or brought in by EMS. And we have an area where all the mid-level providers and the residents and the chief sits, and they'll say, I have a patient that's here with decreased fetal movement. And usually the midwives don't take the complicated postpartum patients or the antepartum patients, like the pretermer patients with the complications. And so usually the PAs will pick up those patients. And, I have a patient with decreased fetal movement, or I have a 22-weeker that fainted I had today. And then one of the PAs will say, okay, I'll take the patient. And then we'll go in on our own. We'll assess the patient. We'll do a history of physical. We'll do a sonogram. We'll let the nurse know I want IV on the patient. I want these labs on the patient. And I'm going to do this on the patient. When you finish assessing the patient, and then you come to your differentials and an assessment and plan on your own after assessing the patient, then you let the chief of service know, like, hey, the biggest thing is keeping everybody in the loop with communication, whether you're the chief of service, whether you're a PA or the midwife, or the attending covering the floor, there needs to be constant communication. And so you're always going to have to relay to somebody, not to kind of double check you, because we all make mistakes, right? But more importantly, just to keep everybody in communication about what's going on the floor. So after I see the patient on my own, I say, hey, we have a patient in this room that's this and that and that, and she presents like this, and I did a sono, this was the BAPP, AFI, blah, blah, blah. I ordered this for her, I'm going to put her on this, I'm going to do this, and this is what my plan is. Then the chief will say, okay, great. Okay, and then that's it. So just so we are all in communication about what is going on the floor. We can delegate, patients and tasks for the level of importance, and also in terms of kind of like managing triage, like, okay, this patient can go home, this patient is going inside to labor, we need to clear out triage to get more patients in. So all of that, all of these moving parts are important for communication. So that's where there's a lot of autonomy. Okay. And so that's pretty much it. The conversations happen to keep everybody in the loop.
Wow, that's amazing.
Yeah.
Really seems super autonomous, and seems like you have a lot of fun and you get to do everything not everything on your own, but
yeah, pretty much. I mean, I get to do a lot. There's a lot of other things that happen on the other side where, like I said, I haven't been doing vaginal births as of recently because of the C-sections. But I mean, because I've been first assisting, I'll go to the OR, maybe with a doctor I haven't worked with before, and I say, hey, do I mind if I come in and I first assist with you? I've been first assisting. It's like, okay, don't worry, let me go in. If you're not comfortable, then you can stop me. Okay, that's another thing. You want to always like push yourself, right? Don't just take no for an answer. And I went to the OR with this doctor I haven't worked with before, and it's like, okay, I'm going to show you. And I'm like, okay. So then, we did a timeout and everything. And I was like, scalpel to me. I told the surgical tech, scalpel to me. He's like, oh, scalpel. I'm like, scalpel to me, and I was like, I got it. And I was like, I'm going to make the incision here. And I was like, scalpel. And he was like, oh, okay. And I was like, okay. And then I was moving and I was like, Coker, Alice, so once he sees that, I'm calling out instruments and tools, and he has an idea that I have guidance. I understand what I'm doing, what I'm working towards. And there's a conversation in the OR, right? It's dense. Okay, I'm looking for fascia. Like, don't go too far down. Just use the tip of the blade or use the tip of this. It's like, oh yeah, you want to use this because you want to expose the fascia or not to get through the muscle. So when you have that dance and you have that communication, it lets the provider know, okay, this person is aware of what they're doing and why they're doing it. Then you kind of can like breathe a sigh of relief, right? When you're working with somebody like that. And then next time, guess what? There's an argument about who's taking the scalpel, but I'm that person that's like, scalpel to me. And I tell everybody and they're like cracking up in triage. And I'm like, I don't want you to take the scalpel and then talk me to death in the OR. Like, I want to move. Like, let's get the scalpel. Let's get the baby out. Give me the Vicryl. And I'm suturing up the hysterotomy. And yeah, I love it, So those are the great parts of autonomy that I get. And then there's other things when you're laboring patients. Like I said, I haven't done vaginal deliveries in a while. So there's things you do to assist in vaginal deliveries as well, like balloon placements or other things. And I haven't done that as much because I haven't been doing vaginal deliveries as much. But there's definitely a good amount of autonomy.
That's so awesome. Yeah. Sounds so exciting. Oh gosh. So how often do you work with a doctor that you haven't worked with before in the OR?
When it comes to the OR, quite a bit. At my hospital in particular, there are a lot of providers. We have a large patient population. We deliver about 9,000 to 10,000 babies a year. I think we're like number one or number two. We're number one in Brooklyn, I believe, and number two, I think in the tri-state, I believe. We have a large volume. Part of that is our location. We're in a location where, mothers tend to have 10 to 12 to 13 babies at times. So we have a large amount of volume. So a lot of times we have different groups of doctors that come in with their private patients within the neighboring area. And so there are times I may meet one doctor from the group, but not the other two until 4 or 5 months in. There are providers that I still haven't met to this day, and I've been working there for over a year now. So, it depends on the days that they come in for their surgeries and procedures and things like that. Most of them I've met. I'd say about 90%, 95% I've met. But I'm the only PA that actually scrubs into the OR, and that's new for everybody. And so when you see that, you're kind of like, well, none of the PAs ever scrubbed in before. So everybody gets a little weird. You're like, is there a change? Is there something going on that I don't know about? And it's like, no, it's just for additional coverage. And I was hired to be in the OR, and I have a passion for the OR, and then, like I said, you sell yourself, I want to go to the OR. Do you mind if I first assist? It's like, when you see that, just let me start. If you're not comfortable, then you can always stop me. Then you allow reassurance, right? You're letting the person know, hey, I'm comfortable taking direction and I'm comfortable with you saying that I'm not comfortable. Let's switch positions. And once you let the person know that you're amenable to that, then you can fight for the scalpel.
That's crazy. I can't believe there's still people that you haven't met. Such a huge
It's a
place.
large, yeah, there are a large amount of doctors that rotate through my hospital.
But that's such good advice for you to have, for you to give, is to be able to take charge and step up. So you don't want to be someone that's stepped over and you're just standing there, and you
Yeah.
show them that you know what you're doing and you want to help.
Even as a student, I tell students, there's nothing wrong with, selling yourself or being slightly aggressive, not overly aggressive, not cocky, but there are times as a student I would put my hand over the body and say, "Hey, like, oh, can I suture?" Or, oh, hand me the, whatever Vicryl, and I'd put my hand out like, okay, like, give it to me, I'll take it, and they look at me like, who is this person? And I'm like, look, we've gone past the big parts, right? We've closed up the uterus, we've closed the starting. Now we're on something like fascia or like skin and stuff. I'm like, let me throw a couple of throws, a couple of sutures. If you're not happy with it, you can always take it out, right? Like, what's the worst that can happen? You can always take it out. But if you're happy with it, then good. You can kind of relax the rest of the case and let me finish. That sounds good too. And they're like, yeah, you know what? You're right. And then once you show them that you're interested in learning and, even if you're not perfect at the beginning, once you're open to learning and you're open to asking, then they'll say, oh, this is a student that takes initiative and has incentive. And, you know, preceptors and providers really take heed to that. They don't want to have to hold you by the hand. They want you to show that you are interested and you want to learn. So you have to be a little bit more aggressive, to be able to get the experience you want sometimes. And it pays off.
Definitely, definitely. Yeah. Reagan in the chat is actually saying, I love your confidence and assertion. It's the dream. Definitely.
I mean, everybody doesn't have it, to be quite honest. Some people are a little bit more introvert, but I think that there are ways you can introduce yourself to a field, especially a field that you're passionate about. Even if it's not necessarily the OR, you can go into delivery. Hey, do you mind if I come in on this vaginal delivery? I'm really interested in the OBGYN. And guess what? You tail that doctor the whole day. Hey, do you mind if I come into, you can see 20 deliveries. Once you start asking and they say, oh, wait, didn't you just ask me to see the last delivery? And they see that the passion is there because the drive is there. They'll say, you know what? Why don't you come in and deliver the placenta? And then you start with something. Next time is, oh, you know what? Why don't you come in and let me help you deliver the baby? Once you start doing these things to show the incentive, then they'll be willing to allow you to do a lot more.
Definitely, definitely. And you won't get it if you don't ask,
Absolutely. Closed mouths don't get fed.
Yeah. Let me see here. So somebody was asking, to piggyback off what you said earlier. Where did it go? So somebody was asking, how come you're the only PA that scrubs in the OR?
It's really about preference. I have a large passion for surgery. I love surgery. It's actually my number one passion. And so I fell in love with OBGYN because I didn't realize how much OB time, like OR time there was in conjunction with medicine. And so when I saw that you were able to practice medicine, be a part of women's health and empower women and be able to go into the OR, I'm like, well, it's the best of like both worlds, right? Unfortunately, my coworkers just don't have an interest for the OR. They just don't. But I do, and better for me because it's just more practice and more exposure time. There is one other PA that is expressing some interest, but it's just a little different in terms of, I think, ability in the OR. So it's just sometimes easier to take somebody with a little bit more, I guess, experience and just move a little faster sometimes. So it's just really about me having the passion and the preference to do it. And that's really it. Yeah. Now they're asking the other PAs. Now they're like, oh, well, Trisha's actually really good. She can like probably teach the interns in the incoming class. And they're like, wow, like you're good. You're really good. And I'm like, oh, okay, great. Thanks. Next time, like we can scrub in together and you could just like hang out in the corner and let me start beginning to end, like solo. And we laugh about that. And now they're like, oh, we should get all the PAs to kind of like scrub in. And I'm like, well, if they don't want to, it's not like a push and an initiative for everyone if they don't want to. But I think that if a few want to do it, it's totally fantastic. Also, side note, having surgical skill is an extra asset, which means more pay. Okay. So yes, and a lot of people don't know that. And I actually didn't learn that until one of the attendings told me, like, Trish, you can increase your salary by like 20% having an extra skill set, like being a surgical PA, because that's huge. Having those skills are absolutely huge. You know, a lot of people can take a history and do a physical, but having skill set in the OR, helping when people are shorthanded, is very, very beneficial. To any facility that you're going to be working in. So that's also a bonus.
Wow, see, there you go. And that's what we mean earlier about, we love how upfront you are, because that's something I feel like, you know, some people don't really like talking about, but that's some information that's really good for everyone to know for the future, is if you have that extra skill set, that's really important.
Yeah, for sure.
Let's see here. So let's see. What does a daily schedule look like for you?
So a daily schedule for me, like I said, I do 2 days of OB and I do 1 day in GYN. So that means I work predominantly in obstetrics, which I love and I prefer over GYN. So I come in and I, come in triage, and I am essentially in triage all day. If triage is well managed, which is the priority, then I go into the C-sections. I don't have assigned or designated sections. Whenever the sections are going, I just jump in and say, hey, can I assist in the section? And that's how it goes. Fridays are days that we have, the residents are gone and the PAs essentially run the service. So we have what we call protected time, where the residents have lectures from sign out to about noon. And the PAs run the service and see patients come in and et cetera. And because we're short-handed, that's the time that I really get to thrive in the OR on Fridays. And I'm the go-to person in the OR with the attendings. I mean, I've done 3 to 4 cases back to back. They've pulled me in one case and, thrown me in another midway through, like, oh, this patient is done. Can you close? The provider's leaving, going to start another C-section. We have an emergency C-section coming into the other OR. They leave and I close on my own. And it's like, okay, meet me in 3 when you're done, So that's the fantastic part about having the extra skill set and being able to practice and get in. So those are essentially like my Friday mornings, and afternoons are essentially like my Wednesdays, where I spend the day in triage and I see the patients that are coming in with whatever obstetrical complaints they may be having. And then GYN also pre-post-op, and then a lot of consults really on the floor or from outside services. I hope that answered anything. If there's anything more specific, I'd be more than happy to answer. It's so much in a day, so.
Oh, awesome. So I think someone was asking, so how long are your days usually?
So I'm actually a part-timer and I sometimes forget, and everybody actually forgets because it's like I'm there forever. I work a total of 31 hours, and that just happened to be a technical thing when I applied for the job, as opposed to like the 39 and 40 hours. But I work an 8-hour day, a 9-hour day, and then Fridays is always my 12-hour day, which is always super hectic and the most draining day of all. So that's essentially, yeah. And I have a very rare schedule. I have a fixed schedule, which is Wednesday, Thursday, Friday. I'm off 4 days in a row. I don't work weekends and I don't work nights and I don't work holidays. So it's the sweetest schedule you can imagine, because as a PA or most medical providers, there is no such thing as a fixed schedule and not rotating at least the holiday. So it's a really good schedule that I have.
Wow, that is amazing. That's the dream.
Yeah,
and then somebody is asking here, let's see. How have you been able to get the confidence to ask to help in procedures like those? And any recommendations for more confidence?
Okay. Is this person asking specifically for the OR or just in general? I'm going to answer like a general question, including the OR. I presume it's probably in general, right?
Well, she was asking for confidence to ask to help in procedures, but I guess for more confidence for herself, I guess more general.
I think the best way to build confidence is to be sure in what you know and know what you don't know, right? And so being able to say like, oh, can I do a couple of throw a couple of, can I do a couple of throws basically in the OR? Can I just do a couple of stitches? If you haven't practiced doing that, then you shouldn't ask. You know, you don't want to go in blindly and aimlessly. You always want to go in prepared for something, and because you want to showcase your strengths, right? And that's what makes you stand out more, essentially. And then once people see that you know what you're talking about and you know what you're doing, um, and you're interested, then people tend to perk up and pay more attention to you. You know, the reason I got this job at the hospital that I rotated at is because they distinctly remembered me as a student, like from the chief to the chair of the service to the residents. And every rotation that you go on is essentially a job interview. So it's really important to put your best foot forward each and every rotation, even if it's not necessarily a specialty you like, because it is an opportunity to network for maybe another position on another floor or another service in the same hospital. That's really important. So I think that the most important thing is to be prepared. Once you're prepared and you're sure in what you know, um, and you're honest about what you don't know, then you can present yourself in a certain way, right? You can say, hey, you know, I'd like to, you can say, hey, I'd like to do a couple of stitches here in the OR because I've been practicing my suturing skills. And then, like I said, you're gonna get some reluctant people, but when you provide reassurance, then that makes people feel more comfortable. You know, I've gotten people like, even skin, and some people are like, I don't know if I should let you close skin because, you know, it's really important. It's what the patient sees aesthetically. You know, it doesn't matter how ugly the uterus looks, as long as it's hemostatic, there's no bleeding, fine, I don't care. But the patient only sees the skin, so you want to make sure it looks good. And so when I say, okay, well, you know what, how about I start and I just do a few. And if you're not comfortable with that, we can always take it out, right? And at this point, we're at the end, right? So what's the harm in doing like 2-3 throws and then you taking it out? What, you lose like 5 minutes, maybe 10 minutes tops. But if I keep doing well and you can guide me through and I can do it on my own, fantastic. Guess what? I'm gonna look for that resident that I worked with or that attending who saw me and said, wow, good job, and then asked to do another case with them. And then when you do another case, you go into another case with another resident or another attending with them, they'll vouch for you. Like as a student, I had a resident I was with, and I was like, hey, do you mind if I actually close? He's like, oh, I don't know. And I said the same thing. Well, you know, I want to practice, you know, I'm here to learn, right? So if I do a couple and you don't like it, we can always take it out, right? What's the harm in that? And he's like, I'm like, come on, just a few. And he's like, okay, fine. It's like, oh, you did a really good job. I'm like, okay, are you doing the next C-section? He's like, yeah. I'm like, okay, I'm going to be right there with you. And then guess what? I'm like, okay, can I close? And now that he's seen my work, he's like, yep, sure. Hand the needle to her. He tells the surgical tech. And they're like, oh, and he's like, nope, give her the needle. And the tending was like, I don't know, skin. Oh no, I was in the case with her last time. She closed skin and she did a great job. And that's how you start to build, you know? And then once that attending sees you do a good job, you go to another case with him or her and you kind of piggyback off of that. And the doctors talk, the chiefs talk, the PAs talk. It's like, oh yeah, I did a case with her actually. She was really good. She's been practicing her this and that, or she did this well, or he did that well. And then it allows for more exposure. So, you know, be prepared, practice. And like I said, closed mouths don't get fed. It doesn't hurt to ask, what's the worst that can happen? Somebody says no, right? But somebody's going to say yes and let you try. And that's the most important part.
Definitely. That's amazing. Yeah, you definitely shouldn't be afraid to put yourself out there. That's how you're going to learn more. That's how you're going to build, like you said, reputation with them. And definitely.
Yeah, 100%.
And let's see here. So somebody's asking, how did you become a surgical PA? A few people are agreeing with that one right there.
So the way my job works is they wanted somebody to help give an extra hand in the OR because, like I said, we have a huge patient load. And so there are times when we have scheduled C-sections. People come in for their like appointed times. And then there are a lot of times where we're going to have an emergency or stat C-section. Okay. And let's say we have 4 C-sections for the day. We only have X amount of residents and PAs. You're not going to put all your residents in the OR, right? You only have designated residents to do certain cases. And then it's not like you're going to grab another attending off the floor. So you're going to need help and support, right? So that's when a conversation was had like, hey, you know what? I told my vice chair, hey, I'm really interested in going to the OR and working up to first assist. That's really one of my goals, and that's what I really want to do. This is upon hiring. Yes, Trish, we would love for you to work as a surgical PA here and assist us when we're shorthanded, especially. It would be extremely beneficial to us. Okay, fine, fantastic. And so I noticed that I got some pushback at the beginning because, like I said, I'm the only PA really that was pushing to go in. And so everybody's kind of like, why is this PA going in all of a sudden, And so I explained, I'm working up to first assist. And then as I went in the OR and people saw my skill set and my willingness to learn and my passion for it, then they started talking to each other like, oh, Trish is really good. Actually, you need help. You should actually ask Trish to go to the OR. Then it became a thing where it was, who's going to the OR with Dr. So-and-so? Where's Trish? Is Trish doing this case? And I'm like, oh no, it's Dr. So-and-so. It's like, oh, you're not doing it? Because it just became the norm at some point because we're so shorthanded. Like I said, I was jumping, the doctor scrubbed out and I was left by myself to close completely, finish up cleaning, bring the patient to PACU, jump into the next OR and do the same thing. Because the demand was there for it and because I also was my own advocate and I expressed where I had a passion and I expressed that I wanted to grow. And I also expressed that it would be beneficial to the team. So, you have to remember that the hospital is like a corporation, it's a business, right? And so by any means where you can provide an extra skill or an extra asset to the team, you're going to be beneficial to the team, right? And even if, I say, hey, I want a 20% raise or whatever it is, increase because I have this new surgical skill set that I'm now officially working as a full-on first assist, paying me that 20% is going to be way less than paying another, MD to come in and assist for the day. So there's a huge cost ratio, benefit and analysis, right, that they do in the hospital. Everything comes down to money because it's a business, unfortunately. But that's the reality. So, hey, why not have somebody that's already employed, has a relationship with the providers, is gaining the experience, and now provides us with a skill set that financially makes sense for us and is beneficial to the team. So if you have a passion for something that may not necessarily be present at your hospital or your clinic or wherever it is that you're working, if it creates an avenue for growth that's going to, help drive revenue, promote growth, or put your facility, your hospital on the map, nobody's going to say no. Nobody's going to say no. You know what I mean? So all of those things make sense on both sides. So I get to, be a part of my passion, and I also get to upsell it. And I say, hey, the more time I get to spend in the OR, the more beneficial it'll be when we're shorthanded on Fridays and the residents are gone. I can first assist. Oh, you know what? Instead of paying the third attending a full attending salary for the day, Trisha's already here with her regular salary, and once I'm full on first assist, and then I say, hey, it's time to discuss some things here. I'd like to negotiate my salary. I lay my cards on the table. So those things are important. As long as you have something you're passionate about that will be beneficial, you provide it, and bring it up to the team, your chairman, your administrator, whomever it is that's responsible for those things, and you express your passion and create an avenue. That's it.
Wow, yeah, and definitely, just like you said, you've got to be your own advocate. So you really got to know what you can put out there, what you're putting out there, and what you know. So that's incredible.
Yeah.
Did it ever get overwhelming for you being shorthanded for you to be in the OR? I know you mentioned you did 3 back-to-back and they were pulling you. Did that ever get overwhelming?
Oh no, I love it.
And you know how you said that none of the other PAs assist.
I mean, the thing is, first of all, I love the fact that the attending can say, do you mind if I step out while you close? That feels good. So, no, go ahead. Go on lunch. I had an attending the other day say, do you mind closing? I have a bun in the oven that's rising. Literally like worried about her. And I'm like, okay, sure, whatever. Okay, bye. You get some characters and some people, but it feels good that there's a level of trust and confidence in me to be able to leave me alone with your patient and trust me with your patient to finish, closing on that patient, and especially doing something like skin. um, it feels good. So that just creates a buildup. And then once you do one, you get more confident in the next section you do. So then what happens is I leave one, I go to the other one, I move faster, it's just more practice. Your hand techniques and your movements improve, everything. I've gone to the OR with an attending and she's like, I did one case, it was good. And she gave me, a lot of good feedback and everything. And the next case I went to, it was the first time working with this particular physician in the OR, and she looked a little hesitant. I said, "Don't worry, I just came out of a case with Doctor so and so." She's like, "Okay," and she's like, "What have you done?" I said, "Everything." She's like, "Okay, go." And I said, "Scalpel to me," and then I started. I'm like, "Give me Alice, Coker, pick up whatever, blah blah blah." I called them. I kept going. Okay, we're down a muscle. Okay. Knife back, pull, whatever, blah, 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 everything else. Okay, uterine, baby's out, suction, placenta, blah, blah, blah. And she said nothing. And I was like, give me a zero Vicryl. Can I get 2 Allops T-clamps, clamp? I'm like, I'm going to start here. And I'll say, okay, tell me where you want it. I throw the suture. Okay, that's good there. Keep it going. Okay, lock me. That's it. Boom, boom, boom. Tie me, clamp. Can I get a this and that? And she's like, okay, so you're really confident in the OR. But she let me do it all. And I said, yeah. I said, you tell me what you like, because everybody's different. And you'll learn that, But having the opportunity to go into the OR for the first time, when you go in right after back to back, you already build up so much experience and confidence. You're like, okay, I'm going to move faster in the next one. And I'm going to get like my wrist movement a little better. And so that's kind of like, it drives me, And so I just want to get to the point where it's like, okay, now I'm like completely, confidently, totally full assist. There's no questions, no hesitations, no matter who I'm working with. Everybody knows Trisha's first assist. I need hands. Let's get Trisha in the OR, and that's it. And that's the goal. So I welcome it. I absolutely love it. I have been in the OR all day. I don't take a break. I'm exhausted, but I am happy. I go home and I am so happy. I'm like, this was like the best day, So once you do something you love, it never feels like work, right? And that's the most important thing.
That is awesome. You are so inspiring. It's everything you're saying is just so motivating.
Yeah, I think anybody can do it. I think a lot of times people are intimidated by like, just the word no.
Right.
And I'm like, okay, what happens if they say no? Guess what? You practice a little bit more, you read a little bit more, or you try with somebody else. And then somebody's going to say yes. And then when you do well with this person, they'll talk to the other person. And that's it. And after every case, I say, thank you for the opportunity to scrub. Can you give me feedback? And I welcome it. I wholeheartedly welcome it because I just want to improve to become a better surgical PA, and that's it. I welcome it all. So it's important.
Definitely.
Yeah.
So kind of related to this. So someone's asking, how did you feel your clinicals prepared you for real life application?
So my clinicals definitely prepared me. I will say that clinicals are one of the things that will definitely prepare you the most when you're going to be entering the workforce. Because like I said, you can read as much as you'd like to read, but nothing prepares you for the real world. I don't care how many like plastic dummies and simulation mannequins that you have that give you like, that red dyed blood when you stick, the needle end and get an IV. Yeah, right. Like nothing compares to, when you stick that little mannequin, that dummy, and you're like, oh, I got flashback. Oh, I'm in the vein. Yay. It's not the same when you go there and the patient's like, ow, ow. And you're sweating and you're like, oh my God, I'm hurting the patient. Oh my gosh, I'm in the wrong place. Nobody prepares you for that. Nobody prepares you for like, elderly skin or rolling veins or, patients that are like screaming. It's not the same, I'm in the OR suturing and my patient's on the table and the patient is vomiting and bucking on the table. Nobody prepares you for nothing in the classroom is going to prepare you. Once you get to the clinicals, you see real people. You get to really apply the knowledge that you have. And when you see results, it's encouraging. It's like, I do know what I'm talking about, because it's scary. It's like, oh my gosh, how do I go from didactic to clinicals and really see people, so much more than you think? Like, be confident in your ability and your knowledge, and be patient with yourself, because it's a learning curve. But clinicals, like I said, it'll show you what you really are passionate about, what you're good in. Um, and no pig's feet or banana peel will prepare you enough with water and soap, whatever they're doing on their hands with gloves. It doesn't feel the same as, like, having blood on your gloves or cerebrospinous fluid and you're suturing. Nothing compares to actually doing it. And so when you actually get that experience, then you really understand what it feels like. Um, and like I said, you figure out what it is that you like and what you don't like. So it helps a lot, for sure.
Definitely.
Yeah.
And so we're going to go backwards a little bit. So someone's asking, do you take call?
I don't take call. I have a good schedule, guys. I don't take call. I don't. I think that most specialties that take call are surgical specialties usually. And OBGYN is a surgical specialty, right? Because they're also surgeons. But it's because it's predominantly OBGYN. It's not like I'm in general surgery. If I was full-time general surgery, I would have a call. I had a job I applied to that fell through before this job. And there was definitely call. There was late night shift. There was a rotation for a weekend. It's a lot. But thankfully, I don't, because this is predominantly OBGYN, where I do have surgical experience. But usually it's the surgery specialties. Like, if you're doing like general surgery or urology and surgery, like specifically working in surgery directly and not just like floor clinic work, that will take call.
That's an incredible schedule. Did you get to negotiate your schedule?
No, it just happened to work out that way. Somebody had left the hospital and I was coming in to take that person's schedule. And essentially she was like plugged in Monday, Thursday, and Friday. They tried to give me a whole different schedule, like Monday, Wednesday. I said, no. I was like, I was told I was coming in to pick up this person's schedule and shift, which was on Wednesday, Thursday, Friday. That's what I discussed. That was confirmed. And that's what it's going to be. And they're like, the secretary was like, oh, well, I'm like, nope, you confirm with the chair, but this is what it is. And then that was it. Yeah, I had room. I did have some room to negotiate a bit. They are pretty flexible. Some days, obviously, they need you there for. Other days, a little bit more negotiable. That's also something you can negotiate too. You can always try and negotiate scheduling, but there are some days that are they just need you to fulfill the demand and the need there.
Wow, that's awesome. And going back to, like I said earlier, the amount of assertion you have is incredible. I'm shy myself and I'm trying to work on that and be a bit more assertive, but it's like, I feel like a long time ago, me would have been like, oh, okay. But now like, no.
Yeah. I mean, I'm bossy, and it helps in moments like this, when you're learning at work and stuff. But I wasn't like this always growing up. I learned that if you don't speak up, people won't listen.
Right.
Don't speak up, you won't get to do anything. I was like very quiet, very shy, very insecure, like from elementary and on. And we all have our issues and insecurities and still about some things, right? But I learned from a very early age that if I don't speak up for something that I want, or I don't speak to captivate the audience and convey what it is that I want, it won't happen. And then you hear like, well, why didn't you ask? And it's like, wow, who do I have to blame? Myself, right? So that's really important. It doesn't necessarily mean you have to be mean about your tone. Just be firm and confident what you're asking for. And that's it. It'll take you a lot further than you think.
Definitely.
Yeah.
And someone is asking, why do you think you stood out during your rotations?
I mean, the type of student I am, I always like to make sure that I'm the best that I can be, right? And also I understood that going to clinical rotation was a huge plus and networking for any future possible job, okay? I'll share a story. But I was on a rotation. There was a PA on the floor. And, a lot of people work multiple jobs, right? Like I do. There's a PA on the floor and I heard him talking to another PA, and he was ripping the student apart. Oh my gosh. She's like, I didn't even know if that student like spoke English, because the student, like, I would be asking questions and just looking at me and like lost. Like I couldn't believe it. It was so bad. He called the like clinical coordinator to complain, and they did not want to like pass. It was bad. And it was my classmate. It was my classmate, but the PA was not working their full-time job. They were working their per diem job where I was doing my rotation. And my classmate was rotating with this PA at his main job. And I'm like, here this person is on their per diem job, ripping the student apart to the other PA. And what does that mean? That means, oh my gosh, if you have that student for another rotation somewhere or at the other job that you're at, oh, good luck to you. Oh, don't even bother with that. And I'm like, yikes. So it's really important. People talk. It's really important to put your best foot forward and really be the best that you can be. And rotations can be grueling, and being in school can be grueling and daunting, and it's a process, right? We all have to go through it, and that too shall pass. So just be patient with yourself in the process. The difference in you performing as a student can literally guarantee you a job, right? Like, the job that I applied to do surgery fell through, and then this position happened to open up. And I said, all right, I'll apply. And they're like, oh, Trish, yeah, we remember you as a student. You want the job or not? A year plus later. And so when you work hard as a student, so I made sure that I took initiative. An important thing is to make sure you can assess the situation. A lot of students that we get now are not assessing the situation, right? If a patient comes in and we hear like the patient is bleeding and people are running around frantic, it's not the time to like ask me questions. Like, we have to manage the patient. Even if saying you want to be involved, trail after me, stand in the corner. You see like, oh, the nurse is looking to grab labs, put the tubes out for the nurse, turn around, here you go. The labs come back, oh, can you print the label? And neither ran up to the lab. You as a student say, I'll walk them up myself. They'll look at you and say, oh, okay. They'll remember that. And that's how that's how you really try to go above and beyond as a student and make a mark during your rotations, to really be available and accessible. If you see somebody going somewhere and they're walking with like a pep in their step, something might be going on. That's the person you want to follow, right? And I tell students, like, if you see me moving with an ultrasound machine or anybody else, you come, hey, I see you're going with the ultrasound. Do you mind if I come with you to just take a look? It's all a learning experience, all of it. And so when you take those initiatives, I'll never forget my very first couple of days as a student. There was an emergency case. I honestly don't even remember the case at this point. I think the patient was abrupting. So basically she was hemorrhaging. Okay. The placenta ripped apart from the wall. She was hemorrhaging. Blood could have filled the sac, killed baby. That's an emergency situation. We're taking you to the OR. We need numbers to find out where the blood level is starting. If we're going to transfuse, get blood from the blood bank directly to the OR to transfuse the patient. It's crazy and it's frantic. I stay away from the area, but close enough if they need help, right? So I'm across the hall. I'm standing, I'm watching, and I'm listening. We need the labs. We need the labs. We need the labs. I go to the nurse and I go, hi, okay, I'm the PA student. I can take the labs upstairs by myself. He's like, oh, okay, you're going to take the labs? I said, yep, I'll take them myself. I grab the labs. I tell the chief, hey, so-and-so, Jess, I'm going to take the labs upstairs. Okay, great. Can you wait for the results? Yes. I take the labs and say, hey, I need the CBC right away. Guess what? I called her. I said, hey, the patient's H&H is this. This is the platelets. Great. I run down to the OR. Guess what? She turns around. You're coming to the OR with me in this section. Because I did that, she provided an opportunity for me to learn and be involved in something that was like extraordinary as a student. So taking an initiative in something that may be so simple as like carrying a lab, but being available and showing dedication to something can grant you a lot of opportunities in the rotation. And from that point forward, if there was a case I wanted to go in, nobody told me no. I was like, I actually want to go into that robotic case for the ruptured ectopic. I already did those cases before. I was like, oh, okay, Trish, sure, no problem. Like, hey, do you need help with this? Oh, you have a consult? Do you mind if I come and learn? Sure. It's like, hi, how are you? I'm the student. I stay in the corner. I don't ask questions. When everything is done and I see it's not an emergent situation, I then say, hey, do you mind if I ask you a question? I'm just curious about something. Sure. Oh, I realized that you said this and I wasn't sure about that. Can you explain that to me a little bit more? Terms I don't understand, I would like Google in the corner of my phone and say, can you explain to me more about, X, Y, and Z? Because I read that it meant this. Like, wow, what did you know about that? That's how you move smart, and you show interest and initiative. So when you do those things, it really pays forward rotations, in the workforce.
Definitely, definitely, yeah. And I feel like another important skill set is being able to read the room. Like you said, if
Absolutely.
there's an emergency, don't start asking questions. Just kind of stand back and see where you could help if you can.
It's an emergency, and the student's like, hey, let me know if you need any help. And it's like, okay, like that's not what I expect from you. But it's not my role to force you to be involved or interested. Okay. And I think students forget that, right?
Right.
Because we're clinicians and we're providers. So when the patient comes through the door, my priority is not to look for the student and say, hey, can you come along? My priority is to manage my patient. But you as a student, your priority is to show interest and tag along, because then you're granted these opportunities. And, it's better for you. Like I said, these experiences granted me a job, so it's important.
Yeah, definitely. That's so impressive too. Someone was asking, so there are a few pre-PA questions for you. So why did you choose the PA program you attended?
So I went to school originally for respiratory therapy at Stony Brook University, which is far out in Long Island. It was predominantly Caucasian and Asian, which is fine. It was a fantastic school, and I absolutely love Stony Brook, and I'm very, very proud of my education there. And it really prepared me for, my future, even as a PA, actually. So they're fantastic. But an important thing is loans, right? So most of my loans from undergrad came from housing. So I'm like, oh, holy cow, all of this from housing? So here I was going to grad school, and I'm like, well, now I'm with my now husband. I don't want to be far, and I want to be somewhere that's more diverse, where I get to treat a different patient population. And I want to be somewhere that's more cost effective. And so I was really determined to attend SUNY Downstate because it was located in the heart of Brooklyn in Flatbush, where there's low income population, poor health literacy, generally speaking, and a lot of ongoing issues in the area that would, I think, better prepare me, clinically. So, and challenge me, which I was really excited about. Not to mention that it's in a location where there's little Caribbean. I'm Caribbean myself, and I'm like, oh, there's going to be great food here. And, so the number one thing was cost. And then the number two thing was location, really. And so I was really determined and the faculty looked like me. It's one of the few schools in the country where you have an actual diverse panel of faculty, from Latino male to African American to Indian to Caucasian and what have you. And to be honest, I think that's really important to see people that look like you in a profession that you're passionate about. And it makes a difference. So.
Definitely. Diversity is a huge thing we feel passionate about, and we try to emphasize on our channel too. So
yeah, absolutely.
How are we doing on time? I just want to make sure I'm respectful.
I don't even know where we're on time. Oh, well, actually, it's about 8 o'clock. But I don't mind. I can continue. If you guys want to hang out with me, we can go over the case real quick.
Sure.
Okay. All right. So I thought that we would talk about something. I like to talk about things that are not widely talked about. Everybody talks about periods. Everybody talks about fibroids, right? And I'm like, okay, I want to talk about something that you don't really hear about. So I thought that we would talk about a cervical cerclage, okay? And a lot of people may not know what this is. Some of you may know what it is. And so I'm going to teach you guys a little something different. So obviously this is a little bit more superficial scale because there's a few things that are a little bit more in depth here, but you guys are going to work with me, okay? So we have a 26-year-old G3P1011 at 24 and 3 presents to triage for a scheduled cerclage. So I'm going to walk through this. G3, okay? So gestation 3, meaning third pregnancy. Third pregnancy, this number represents the patient's current pregnancy. So when you see the number 3, that means the patient is currently pregnant, which means that they had 2 prior pregnancies before. So 2 prior pregnancies, including this current pregnancy, means pregnancy number 3, okay? Parity, para 1, that first digit is for full-term births, okay? The second 0, that represents preterm births. That third number represents miscarriages, abortions. And lastly, the total number of living children, right? Because just because you have a gestation of 3, and let's say 2 prior pregnancies in this case, doesn't necessarily mean that those pregnancies carried to term or was successful. Patients can deliver stillbirth or have abortions, unfortunately, and you would see that represented here. Also, off note, these 2 numbers, along with the current pregnancy, should add up to this number, okay? So if the patient has 1 child at home, had 1 previous loss, totaling 2, this should represent the 2 prior pregnancies, not including the current. Does that make sense? Right? Because this number represents the current pregnancy and the previous pregnancies. So let's say, not including this pregnancy, this number is ideally 2 for 2 prior pregnancies. That 2 should equal these 2 last numbers here. Okay, so we keep that in mind. 24 and 3 is just the gestational age, 24 representing the weeks and 3 representing the days. So 26-year-old, pregnant 3 times, including this pregnancy, history of 1 full-term birth, no preterm, 1 prior loss, and has 1 living child at home. Is at 24 weeks and 3 days gestation. This patient presents to emergency room triage for a scheduled cerclage. Okay, does anybody have any questions about that?
Let's see here. So far, there are no questions, but there is that.
That means I explained it clearly. Okay, that part gets very tricky. Okay, scheduled cerclage. Okay, so here we see on the picture here, this, can you see my arrow where it's moving?
I can, yes.
Okay, so this area, this is the cervix. Okay, this is the cervix. This is what we call the external os or the external opening. And as you insert your fingers, when you do a vaginal exam to determine if the patient is dilated, you go further down into the area of the internal os, which is the connection between the vaginal canal essentially and baby, right? Behind the internal os is where you should be feeling baby. Okay, this is where you'll start to feel dilation, effacement, and how dilated the patient is. Okay. And then here, this is just a picture of the suture. It looks pretty gruesome, okay, going through. And they're basically gonna go around in circles. There's another picture that I'll show, okay? Okay, so what is a cerclage? So it's a surgical maneuver on an incompetent cervix at 12 to 14 weeks gestation, requiring non-absorbable sutures to reinforce the weakened or incompetent cervix. And the 2 techniques that are widely used are called McDonald and Schroedker. McDonald is very, very popular. We use it quite a bit. And it's basically dropping a suture in at the 12 o'clock position and then going to 3, the 6, and the 9, okay? And essentially, an incompetent cervix or weakened cervix is basically a cervix that starts to shorten a lot earlier than it should, okay? So we call it incompetent because it's not doing what it's supposed to do, right? The cervix is known to get a little bit shorter as you progress into your pregnancy, but the normal cervical length is about 4 centimeters, okay? Once you get to about the level about 2.5, then it starts to be a little bit more concerning. Definitely around 1, you're very concerned, more or less, okay? Like I said, it's expected to shrink a little bit, right, to shorten. But there is a point that it gets to, like I said, at 2.5, and that 1 number, that's going to be concerning for the viability or the livelihood of your fetus, okay? So here, as I described, here's the external os, here's what we call the internal os, and then the uterus, okay? And then there is also a different type of cerclage called transvaginal cerclage, and then there's actually transabdominal cerclage. And we'd like to focus more on the transvaginal. Transabdominal is not done so much, but that basically means going through the lower abdomen, making the incision through the abdomen and doing it from there. It's easier physiologically to go through the vagina and do it. The reason to do the transabdominal is usually like if there's some sort of physiological issue or any other complication, preventing the transvaginal direction instead. Okay, so it's not really widely used, but it can be done. Okay, how do we prepare for cerclage? So prior to cerclage, patients' fetuses are screened for any obvious malformations. Patients are tested for gonorrhea, chlamydia, or any infections. A cervical length is performed prior on sonogram. The patient is NPO for 6 hours, meaning no food or drink. You have to have an OR prepared, and anesthesia usually performs a spinal. So cerclages are done in the OR, okay? So I talked about the cerclage being done essentially at 12 to 14 weeks, right? And usually we do it around this time because this is usually around the time where you have a lot of issues with misses. And this is the optimal time to help prevent those misses or abortions from occurring. It happens about 30% of the time for first-time pregnancies, abortions. So having it when the patient has a prior history to an incompetent cervix, having a cerclage around this time is considered optimal, okay? So there is a chance that, and I'll talk about this in the next slide, there's a reason why you wouldn't want to do cerclage if the patient has an infection. Cerclage, you're essentially taking a suture and you're essentially taking this opened, dilated cervix, and you're kind of like tightening it with the sutures around the perimeter, right? So if a person has an active infection, you're basically locking that infection in. You're basically closing that infection in. And then when you have an infection and it spreads to the uterus, all it's going to do is create issues for baby, sepsis, and then a loss, essentially. So you always want to make sure that the patient does not have any active infections, because all you'll do is basically lock that baby in with that infection, cause baby to get sick. You'll end up sick, but obviously the first thing that would be affected is the fetus, okay? Make sure that the patient doesn't eat or drink for 6 hours because this is considered a surgical procedure. And in case things don't go awry, you want to have the OR ready for any possible complications. If the cerclage is not adequate, baby starts to pass through. If you have to do a section, what have you, you have to make sure the OR is prepared for that as well. And spinal to create a block to help for pain, okay? So indications, history of a second trimester birth or loss, right? History of an incompetent cervix or cervical insufficiency, which is essentially the same thing. So if you have recurrent conizations, like cones done in the cervix, you're basically scraping out and cutting out pieces of the cervix. That can in turn cause a lot of weakness in the wall and the musculature of the cervix. Also we call stenosis over time. And those things can lead to having an incompetent or insufficient cervix, increasing the chance of cervical shortening and weakness, okay, in the sequential pregnancy or when you get pregnant after having those procedures. Contraindications, bleeding, contractions, rupture of membranes, or twin gestation, right? Bleeding, essentially, if there's bleeding coming from the area, like through the cervix, is going to come from further up in the uterus. We're concerned. Why is there bleeding? Is the patient having an abruption, right? Is a placenta detached and bleeding? If there's bleeding and you don't know where the bleeding is coming from, and then you take this hole and you tie it up, you're basically blocking that pathway for the blood and essentially tamponading or blocking off the blood, and baby is going to be consumed in that, right? How is baby going to live in that environment? They can't, right? So whether it's from something like an abruption, or even if there is a fibroid, an uncontrolled fibroid that starts bleeding, you can essentially lock in this space where you have the bleeding and essentially trap baby and create complications therefore. Contractions, now we're worried about preterm labor. If the patient's actually in labor, why would you, you can't, create a suture there to lock the baby in also, right? Now we're worried about whether or not we're gonna have a loss, which may be the case depending on the gestational age. Rupture of membranes, the protective barrier that protects baby. Once membranes rupture, we're talking labor, right? There's nothing else obviously we're gonna do there. And then twins, because it's a relative, some people say that you can do it, some people say not so much. It's tough because there's always a high chance for prematurity and complications with twins, so it's safer not to necessarily do it than to do it, okay, for the twin gestation. So just to show a picture here, this is, let's say, ideal, right, for the cervix from here to here. Okay, here's baby head and uterus, amniotic fluid. Here's the external os, internal os, okay? Here we start vagina, external os. And this is what we call a little bit of funneling or opening here, okay? But this, essentially the length here is fine, right? Now here, you see how much shorter this is here between the red lines, right? And look at the difference in the baby's positioning here versus here, right? When you have the shortened cervix, baby's gonna start to migrate downwards. And with gravity, that pressure, baby comes down, as well as the amniotic sac, which is a protective barrier. And essentially, baby can pass. Baby can literally come through and pass through when you have funneling, if the cervix is incompetent. Now, a question I have, are there any agents that can help with cervical shortening? Vaginal progesterone, okay? So vaginal progesterone is really important, especially in the luteal phase. Important thing is depending how much shortening, how far along we are. And also vaginal progesterone is usually the go-to for patients that have cervical shortening, but has not had a history of loss or shortening before. So if this is the first time the patient is experiencing a shortened cervix, hasn't had a miscarriage or abortion from this, then vaginal progesterone is the best way to go. But if the patient has a history of a loss due to incompetent cervix, the best way to go is just to do a cerclage, because it's just going to increase the chance for the patient to have another sequential loss. Okay, so vaginal progesterone is good for shortening of the cervix if they have not had a prior loss, if this is the first time they're experiencing this. Okay, so just to see on sono, it's always a little confusing, especially when your eyes aren't trained, but here in blue is basically the baby's head, the fetus's head, right? This white here is the thickening is the skull. Here's what we call funneling, and it's what we call V-shaped. So funneling means this is the amniotic fluid here. Okay, baby's head is here. The sac that surrounds baby, the cushion and protective barrier for baby, is starting to migrate outwards, okay, from the internal area of the cervix. This is where the internal os would be. It's starting to come down, okay? Here's the area of the cervix here in external os. So once the sac or fluid starts coming from inside to out, the sac encompasses baby. So once that starts to pass, you're making way for the fetus to pass along with it and essentially pass through the cervix, okay? So once you see the sign on ultrasound, so about 16 to 24 weeks, you do cervical length checks about every 2 weeks or so, right? And you measure for what we call the cervical length. The length of the cervix is usually measured. If we see on sonogram, this is just a transabdominal sonogram, signs like funneling, where there's fluid here coming out, we measure the cervical length and it's a lot shorter than expected for the gestational age. We're now concerned for incompetent cervix and increased chance in loss, okay? That's when we talk about progesterone versus cerclage, okay? Now, there's something called a rescue cerclage, which is an emergent situation when the patient has funneling or the cervix is extremely short and they're already dilating. And you don't see that happen too often, but sometimes depending on the gestational age, we can take them to the OR right away. And emergency, meaning last chance kind of thing to help protect baby or hold baby on until they reach a state of viability. Okay, and then there's a chance to actually resuscitate if this patient does happen to deliver up until at least the 24-week gestational age, okay? Okay, so before we talk about what happens next, so 12 to 14 weeks is ideally the best time to get a cerclage. Usually after 24 weeks, cerclages are not performed. Some places may argue and say they'll do it up to 26 weeks, give or take, and some not so much. The idea of not doing a cerclage after 24 weeks is because 24 weeks is what we call viability. When the fetus reaches the age of 24 weeks, if they happen to deliver, we can do full resuscitation on that baby. We'll do everything to save that baby. Anything prior, by the state law, that baby is not considered viable, and therefore we do not attempt full resuscitation, which is why it's important that we attempt a cerclage, especially with known history, at the 12 to 14 week mark, okay? We do that up until the 24-week because 24 weeks, viability. If the patient delivers, we can perform full resuscitation and try to maintain and rescue that fetus's life, okay? Okay, so what happens after cerclage is performed? The patient goes to the OR, cerclage is done. those stitches are done. McDonald's, like I said, 12 o'clock, you literally go in with the suture, right? You go back in at 3 o'clock, 6 o'clock, 9, and you tie your knots. Usually they do that twice all the way around. Before actually doing the cerclage, a vaginal exam is performed to see if the patient is dilated, by how much. At the end of the procedure, you also redo your exam to reassess the same thing and kind of reinforce the fact that the internal os is now essentially locked in and closed with the sutures in place. Okay. So mom and fetus are monitored after. So we're now monitoring for signs of contraction, any issues with baby's fetal heart rate, any signs of stressors or anything like that. After a couple hours of monitoring, the patient will come back for a scheduled removal at 37 weeks in hopes that 14 days later, they'll have what we call a spontaneous or normal vaginal delivery. Is that always the case? No. Sometimes you take out the cerclage and baby and mom ruptures and she goes into labor. But at 37 weeks, there's fetal lung maturity and mom and baby are in a very safe place. So the 37-week mark is very crucial because we know at this point, mommy and baby are going to do very well and have a very high chance of doing well after cerclage. Okay. Do you go home after the cerclage? Absolutely. You don't have to stay in the hospital for 14 days. So essentially you go home with what we call modified daily activities, right? We're not expecting you to go run a marathon or go on the elliptical at the gym. You can return to work, no heavy lifting, anything that's kind of like common sense where you don't want to induce any stressors, nothing that's gravity dependent that will cause issues, in that area, obviously. But you can go back to work, like I said, modified daily activities and go on, at home and try to resume your normal day-to-day until you reach that 37-week mark. Okay. All right. So I have a couple of questions. Did you want to give these questions or should I save them for you?
It's up to you.
Okay.
Do we have time for you to give them or do you want to?
No, I can totally give them. If anybody else wants to answer, you can see what their responses are. Okay. A cerclage will guarantee that I will carry you to 40 weeks. You guys can just upload your answers. You let me know what they're going to say.
Will do. Let's see. It's going to take about a few seconds for them to catch up on the live. So there was somebody in the meantime, there was somebody that asked if an abortion could cause a shortened cervix in future pregnancies.
I would say one is nothing that's too, it's not something that's too concerning. Also depends where, if we're talking about something that's in utero, that's the uterus, then I wouldn't be concerned for that so much. We're talking about things like a conization, where a cone is basically where you're cutting out a piece of the actual cervix, right? An abortion usually, what we call a dilation and curettage or suction or, cutting is usually going to be suction or scraping of the actual uterus that encases the baby. In the bottom of the uterus here, the opening is where we have the cervix, essentially. And the cervix is what is really affected, not the uterus. So having an abortion, which is in the uterus, is not necessarily going to affect the cervix.
Okay, perfect. Thank you. All right, so everybody is answered, or not everybody, but we have a bunch of no's. I think it's unanimous. Everybody's saying no or false.
A cerclage will guarantee that I will. False. Good job. You guys are amazing. Okay, very good. All right, and the next question, what pharmacal agent helps prevent cervical shortening? So we discussed if you have cervical shortening for the first time, you have not had a history of a loss, what is your option other than the cerclage? I'm just gonna grab my charger.
Yeah, definitely, go ahead.
Go ahead and you guys can go ahead and answer.
Got a couple or a few already coming in saying progesterone.
Oh, you guys are so good.
All right, yeah, a bunch of progesterones are coming in now.
Yes, perfect. That's absolutely correct. Okay, and a cerclage elongates the cervix. You guys can answer. I'm just going to charge. Did they get to answer that one?
We have a couple There, it seems to be 50-50. Some are saying true, some are saying false.
Oh, you see? All right, that's really good. So we can talk about that for a little bit. Okay, so the cerclage does not elongate the cervix. It just prevents the cervix from necessarily shortening to the point where the chances for a preterm delivery and loss occurs. Sometimes you have a cervix in place and your cervix can still actually shorten a little bit. But the most important thing is you have that binding with the sutures, right? That prevents the funneling to pass through from the inside to the outside, from that internal os through the external. So that's the most important thing. So it doesn't elongate it. Nothing will elongate the cervix, not even the progesterone. It just really maintains it essentially and helps prevent it from necessarily shortening to a point that can go ahead and precipitate preterm delivery or loss. Was that clear?
Yes, definitely. A lot of the later answers, I think pretty much everyone later was saying no, that it's false.
Okay. Well, I was giving the explanation, right? Just kidding. You guys are awesome. Okay. Women can receive a cerclage at 36 weeks gestation. True or false?
Let's see what they put. Someone said no.
Okay.
Someone else said false. And then someone said they can receive up to 24 weeks.
Ooh, who's a genius? Who's looking for like a gold star? That was going to be my follow-up question. You know, if not 36, then why not? Okay. Can anybody tell me why 24 weeks is the number? We discussed that a little bit.
Let's see. Someone answered no because the fetus is considered viable.
Is that the same person that gave that initial answer?
It's
The genius?
No.
Okay. So up to 24 weeks because the fetus is considered viable. If the patient did deliver, we can do a full resuscitation to try to save that fetus's life. Excellent. Fantastic. All right, guys. You guys are just amazing. So we went over all of this before. And that pretty much concludes cerclage. That's pretty much it. I just thought that it's something that I never heard about until I got to my clinical rotations. And I thought it was so interesting and so cool to see. Doesn't look the best, but to think, there's a high chance for miscarrying. The amniotic fluid is coming out from the internal portion. External is still closed, which is what is the saving grace. If external is open, then that's like a no, okay? If internal is open but external is closed, we just need to keep it from getting to the outside world. So I just thought it was extremely fascinating that even if it looks like there's a high chance for loss, if that external is closed and you're able to kind of like suture in and close that internal area, that's fantastic that you can save that baby's life and help mom carry essentially to term at 37 weeks and have a happy, healthy baby. So there's such, amazing amount of options out there in medicine, especially in the realm of OBGYN. A lot of things like this. I spoke about external cephalic version and C-sections and stuff on another platform. And I think people were really intrigued because you don't hear about these things widely discussed, right? It's really of the latter. People are always talking about fibroids and, menorrhagia and things like that. And I just wanted to talk about something that was different and a little bit more interesting. So I hope you guys enjoyed this. I think it was kind of brief, but really to the point and a little interesting.
Definitely. It's so much appreciated. Thank you so much. Everybody's enjoying it. Everybody in the chat. There's over 300 people watching live right now.
Oh, nice.
Thank
Thank you guys for joining, especially it's like way past time. But I love doing these things. I love giving back to the pre-PA community. I love that you guys get credit. I love what you and Roy are doing. It's absolutely phenomenal for the pre-PA students, and it's a great platform. So, kudos to you guys, and thank you all for joining us tonight.
Thank you so much. Thank you for joining us as well. The presentation was amazing. You're a fantastic teacher. I've actually seen a bunch of people saying that as well, and that everybody seemed to love the little quiz that you gave. Nobody's given a little quiz, and that was really awesome. So thank you so much.
I think it always helps kind of like hone things in, right? And just like reiterate information and help you remember. And sometimes the follow-ups, they help. So you guys did fantastic. Thank you for joining.
Thank you so much. You're awesome.
Thank you.
Thank you. Have a great night.
All right. Good night, guys.
Good night.
Bye.
Bye. Okay, everybody, so let me get this quiz started for you. Da-da-da. Okay, so I dropped the link for the quiz in the chat. It's available for 1 hour, so it'll close at 8:30 p.m. Central. And same format, 5 questions, multiple choice. As long as you answer 4 correctly, you will receive a certificate. And this time we are asking for about 1 to 2 weeks for the certificates. We've had a few issues with the add-on before, so we're kind of backlogged on some of the other certificates. So we're still sending some out. We're going to start doing them manually again. Actually, what we might start doing is we might just send out a request form for whenever you're ready for your final certificate that has your total amount of hours that you've spent with us. So if you attended like 2 1.5-hour sessions and a 2-hour session, you'll get a final certificate with 5 hours. This one will count for 1.5 hours. And like I said, as long as you get 4 out of 5 correct, you'll receive your certificate. And we might start doing the request forms starting next month. So for the rest of this month, we will do a certificate after each session. If you guys have any questions, I'll be here for maybe about 5 to 10 minutes more. So thank you again for joining. Have a good night, everybody.